Good morning, everyone. Thank you so much. And I'm going to say hello to the folks who are joining online, but then I'm going to turn my camera off because you won't see. So hello, good morning, good afternoon, good evening, wherever it is, whatever time it is, wherever you are. Like Theo mentioned, I'm joining from Los Angeles. So it's a bit late where I am, but happy to be here. I want to say thank you also to Bert. I think that there are some keywords that popped out of your presentation that will fold in nicely into it. I'll be presenting today, more specifically, things about de-risking and compliance training. Those are kind of the jams that we work with at Mayo Clinic as well. So my name is Kristelle Jose. I'm a senior design experience researcher at Mayo Clinic. I'm an ethnographer by training, and I came into design research by way of anthropology and ethnography, studying human behavior. So as a researcher, I'm always interested in context and people. Ethnographers are interested in the environment and how that will shape their actions and ultimately their behaviors. Big advocate for doing user research, whatever the situation or problem space. You know, if we claim to be sort of data-driven, we want to do the qualitative research to really back your decisions. So I really love the introductory pieces about user research. And with that, I guarantee you'll learn something numbers didn't tell you. So I have the great honor and pleasure of studying and sitting at this fascinating intersection of medicine and machine learning. I observe regulatory experts who are deploying AI ML models as products into the clinical workspaces. And that transition from model to product is quite difficult and can be a challenging process. So as a UX practitioner, I help them make that process a little easier. Hence the title of this presentation, not all software products are regulated equally. Healthcare in general is a highly regulated space in the United States, but the regulatory experts I work with closely focus on safety and efficacy. So again, not all products are usable, let alone are they safe to use, and I'll go into that in a little bit in just a moment. But maybe I'll just give a brief example of the kind of products that we come into. So oftentimes we'll be presented with a product that's a calculator, right? What is it calculating? And they aim to calculate or produce a risk score that the patient has a serious disease or condition, or that this will likely happen to them. So that's a major moment, and the stakes are very high for everyone, the patient, the physician, as far as responsibility and communicating the most accurate information and then explaining where that information came from. So just briefly, again, I work at Mayo Clinic. It's a nonprofit hospital academic medical center focused on integrated healthcare, education, and research. So actually, in our logo, we have those three shields: research, practice, and education. We're a top-ranked hospital system in the U.S. Our research focuses on diseases and conditions and understanding best clinical practices and translating things from the laboratory setting into the clinical practice. So most of our clinicians actually publish research, and they may also hold teaching positions, as we have several medical programs that cover all medical and surgical specialties. We have over 150 years of patient data, not excluding treating the world's rarest diseases and conditions, severe and complex. Our patients are getting expert care they would not have received elsewhere by medical practitioners. So just to illustrate the kind of data we're dealing with like 10 million patients, 118 million ECGs, or commonly EKGs as well. I'll just throwing you a bunch of numbers to just, again, illustrate what the data we're working with. And the one that surprised me the most was actually 6.2 billion images. And that's a massive amount of images to work with. How do we even begin to prioritize any of that data, right? So in terms of data science, we are data science rich. We have a lot to work with, and we're able to engage with a portfolio of data and digital health solutions. And what we want to do with those is essentially these four goals, right? We want to accelerate the delivery of new cures. We want to advance patient care. We want to enable clinical application. So knowing that have all this information, what do you want to do with it? What clinical problems can we solve or get ahead of, knowing that we have so much data to essentially experiment with? And then lastly, power innovation through having access to that data. So many of our physicians, they don't know that we have X amount of years on a certain type of surgery. How can we help give them that kind of information faster? So the thing that I started to mention earlier, as far as like what our problem is I believe that many of our AI ML devices, which I will constantly interchange product and devices and model, just because it's different to different stages and to different people, just kind of that life cycle of like, where are you? Are you a mature product, or are you just experimenting with some really great data? So anyways, back to the stories. Many of our devices start in research and they want to go into practice and have high hopes and goals to use them in clinical practice, but that transition is super challenging. Things don't always translate, and what I will do in my talk is I'll review some of the most common scenarios we find ourselves in and some of the questions that we also ask ourselves to get us over those hurdles. So the overarching theme, though, when I think about all of these models going from research to practice, is how do we go from a functioning model to product use in the clinical setting? There's a translational gap, there's an implementation gap. So I'm going to briefly describe two scenarios or two thematic areas and the common questions we had to answer while building these AI ML devices. So I'll just begin with this picture. This is a radiologist at their station, and many of the models that we work with, a majority of them do come from the radiology department because they are image-based, and a lot of the tools that we work with are segmentation tools. So we're particularly unique at Mayo Clinic because oftentimes the creators of the algorithms are also the end users. So we have physicians working with data scientists to create solutions for themselves and their peers that ultimately impact patient care. So they're extremely motivated to build AI solutions. They're focused on efficiency and they want to lessen the burden on clinicians. So we can use AI to really offload many of the tasks that clinicians have to do so that they can focus on the patient. But I think whether or not you're building, I guess I'll take a step back. We often have to just straight out of the gate ask, well, what kind of tool are you building? Is it a segmentation tool? Is it a diagnostic tool? Is it a prediction tool? Or is it a body composition tool? These variants all have regulatory implications, and oftentimes the more complex the model, the more regulated. So the less complicated the model, the less compliance is involved. We also have to ask, who does it serve? What diseases or conditions are you trying to really target? And was it only built for that? So I have come across physicians who created an algorithm that worked really well for a specific organ, let's say your kidney. And there are other departments who realize, well, we need that for the spleen and the pancreas. It can do kind of a contour of the same organ. That doesn't necessarily translate. If it's for one body area, it doesn't necessarily translate well for another because that model was trained on the specific size, right? So we often have to kind of educate our physicians on, some application doesn't work well on others. And then who is the end user, which is super common for all of us, but it's actually a difficult question to answer for a lot of clinical experts because it's different from their benefactor. So what kind of health professional are you interested in targeting as an end user? Is it a technician? Is it a care coordinator? Is it a PA? Is it a nurse? So we often hear of different types, but the reason why this question is important to answer is that the right role, are they the right person to be handling this kind of information? You definitely want to avoid a diagnosis to be communicated via the wrong messenger. So does that end user need to be trained on the algorithm itself? And do they need to be trained on how to use this software device? Also, a fair amount of our data science teams, they rarely think about the end user. They think about the data that they have, and then they maybe consider the end user's abilities, characteristics, psychographics at the end of product development. So for the previous image of that radiologist, it was important to understand that the end users for a potential solution might not always be the ones who benefit directly from implementing the actual solution. And then the last one here is, what is the future state? So they describe what they currently have, and then they say, but in 5 months, we hope to achieve this amount of accuracy. So what's the future state? We really had to think about the new optimal workflow to facilitate integration for everyone. So not just the physicians, but who else are you actually involving in this new workflow? Do you understand the clinical problem well enough to intervene and inject or maybe even disrupt with a new tool? I've often done workflow diagrams with different teams, and we find that we're unintentionally adding more steps by injecting a new AI solution. Was that really our goal? And that's a hard lesson because people spend months, years trying to really work on their model and get it to a great state. And then the second story I'll tell you is these are two data scientists at Mayo. They really took this lesson and ran with it. So the way you build your AI ML device could have regulatory implications, right? So the higher the risk associated with the tool, the likelihood it will get regulated like a medical hardware device. So I always say, software as a medical device is a piece of code. Hardware medical device are like things that are implanted in you that still have to be maintained and calibrated, and if something goes wrong, what happens? Same with software, right? So if you make a change in your software and something goes wrong, what needs to happen? That's sort of why the software as a medical device is that big regulatory body that we work with. And what happens if your model goes wrong? What if it produces, an incorrect output? Who do you report that to? What do you do with that? So in my experience, these digital health solutions teams don't build with risk management in mind. They care more about model performance and success measures of the model itself. And the main lesson here really is to evaluate safety and effectiveness prior to clinical use. So often you hear we get the model to a pretty good state where it has passing scores, and then we're going to think about how this goes into the clinical practice. But again, they don't think about how safe is this to use in general before we make that decision. And are we actually increasing and optimizing the workflow of the physician? Okay, so I'm just going to read this really good quote quickly. It's from the data scientist. It is saying that the accuracy of AI is directly proportional to the specificity. So the more you can pinpoint the problem, the more effective and buildable the AI will be. So identifying that purpose, making it clear from the beginning, can reduce costs, avoid misuse, and increase the chances of success. So a lot of times people in this experimentation mode will say, well, we want the model to do this, this, and this. That's great. Maybe we need to downscale a little bit our expectations so it does one specific thing really well, and it's dependable and reliable, and we take that piece forward. We really have to scale back functionality in a lot of our software devices because it's just so complex. And again, the more functionality you have, the more regulated it'll be, the more documentation work that's needed. So the questions that we had to answer when working with data scientists is the software intended for use in diagnosis, cure, mitigation, treatment, or prevention of a disease or condition? FDA actually takes those 5 words differently. Like those are actual categories. Are you diagnosing, or are you curing, or are you mitigating, etc.? So it's really, to simplify it, it's, are you a medical device? Because certain algorithms that we have are about hospital efficiency, not about true medical devices. But it still involves software, and it still involves technical environments. So an example of a non-regulated, non-medical device is like an algorithm that may predict how many beds we have available in 2 months. That doesn't need to be regulated, not as intense, but one that will produce a risk score that you will have cancer in 5 to 7 years, that's very highly regulated. We have to explain how we calculate that. And so the rigor increases. Okay, what can go wrong with using AI ML devices? Loads of things. And so what we find is our AI scientists, who are very closely married to their model and their data, have a hard time with this question. because you're asking them to think in a way where like, what is wrong with your product? And they will likely say, well, I shouldn't say they won't likely say, they don't know the answer yet. And that's what we're here for, is to help them evaluate what are the potential hazards and harms that could come out of your device. And that in itself is a huge process as far as identifying, like going through a risk analysis or risk mitigation strategy. What happens if you change the model? So do you have processes in place when you make a change or an update? You know, software gets updated all the time. How do you treat your model like a digital software product? How will you inform users of a change or update? How will you test and validate that change? Do you have product lifecycle management? So how you handle technical, operational, and model outcome monitoring. And then this is my favorite one. What is the FDA expecting? A lot of documentation. Like this isn't like I turned in my homework type thing. Is like they're asking for pages and thoroughness of, you know, when was this decision made, by whom, what changes did you make to respond to that? They're asking for essentially like having a built-in quality management system for every piece of regulated device. Just a side note and a fun fact, I think in 2018, the FDA in the United States had only 17 medical devices. So if you think about how many models there are out there and how many are, you know, within our own portfolio, that's a very small number. So that level of documentation is very thorough, and you would be surprised as far as like the reasons why they would reject a submission. But that's probably another talk for other experts. If you want to learn more, I'm happy to point you to some. So I just want to leave you all with a few takeaways, and then hopefully we could really have a good debate about what we're presenting, and also maybe other questions that you might have. But my final takeaway actually is only more questions, and really charge you all to think about the direction of AI and the direction it's going in healthcare, and how it rapidly evolves. So how are we as UX practitioners building safe and effective AI ML tools in healthcare? If you do, you know, collaborate with different AI teams in the future, you know, consider asking, you know, how are we, as early as you can we have some sort of safety mindset in place, or can we deepen our understanding of like this impact, not just at patients, but perhaps to like larger communities as well. A data scientist really spoke to me once. He really resonated. He said, it's not even about the data that you have. It's about the data you don't have that you should be worried about, right? Because you could unintentionally be excluding a group of people because you don't have their data. So this will not work for that group of people. And then lastly, what are the ways that UX can lead the way to answer that question? So part of my own personal challenge is really, you know, a lot of times these product teams, they don't have that UX mindset. It's very new to them. But I always try and translate and say, you kind of are a UXer too. You think about ways to improve things. You think about designing your lunch, you're designing your day. You can help participate in this process. And I think Bert mentioned that earlier as far as like collaboration is key. In order to successfully deploy AI models, it's not a singular role that does this. We work with a variety of people to really translate a lot of these models. And just really quickly, it's everything from a data scientist to the clinical expert to project managers, regulatory experts, you know, UX at the very end. But it's really about kind of those change management seekers that help us shepherd a lot of these and champion our AI devices. So with that, I want to leave you with a quote that I think nicely sums up the importance of UX and AI ML work. And you may have already come across this, but I like to refer to this quote: data are not bricks to be stacked, oil to be drilled, gold to be mined, opportunities to be harvested. Data are humans to be seen, may be loved, and hopefully taken care of. And that is by the woman who also worked on the Algorithmic Justice League, and I think was also featured in a Netflix episode or movie. I can't remember the name of it, but I think it's an incredible source of media as far as like the lessons we have with data that we're dealing with. So I would love to take any sort of questions, any comments or thoughts as far as like how you're interpreting this, how you're processing this, intentionally leaving enough time so that we have more of a debate rather than me spewing and continuing to spew.
Thank you very much for your presentation. I was wondering, as a UX practitioner, what ways of thinking and working helped you the most tackling the work that you're doing?
Yeah, so I would say all of my work is discovery. I very rarely tap into kind of the evaluative, tactical research that is what I call micro research, when it comes to like the layout of the actual model output. What has been most helpful to me as far as a researcher is being able to explain user research in a way where other physicians and clinicians understand it, right? So let me give an example. Essentially, I try and say, in addition for me doing my user research, you as a team need to do your own user research, right? So they'll go off and say, we have this amount of data and we think it'll serve these people. And then I say, did you talk to those people? No. Maybe we should. Maybe we should do some stakeholder interviews. Maybe we should just throw, spaghetti at the wall and see if it sticks. The one thing that data scientists really value is like shop around your idea before you even get any code down, right? So things like Wizard of Ozing that I've learned as a UX practitioner is actually super helpful to relay to other teams, right? Even if it doesn't work, what would you say if it worked? How would you react? What would that enable you to do? So to answer your question in a long-winded way, it's to teach user research because ultimately we want to deepen that UX mindset to all of our clinical.
Thanks. So the previous talk is quite interesting to you.
Yes, yes.
Yes, thank you very much for your really interesting presentation. I really like the part also where you explained how you switch from research to practice and your role in that. And I was wondering, do you have maybe an example of a product or a model you were involved in that was finally brought to clinical practice?
Yeah, just give me a moment to think of one. There's a few. So generally in research, this AI is used to advance like some sort of clinical trial, right? So we have a specific disease or condition that has a specific, genetic sequence, and we want to sift through the number of patients that may be good candidates for a clinical trial. And so it ends up being something that's super successful, it's time-saving, and then our clinical arm will say, wait, if you can do that in your lab, we can actually use this information while we're taking care of the patient. So let me think of one. Really the ones that I can probably talk about are the ones that involve genetic sequencing. It helps find patients faster. It helps them become candidates for a clinical trial while they're being cared for as a patient. And that one, every model is different and all of the translation and implementation will be different. But another one that I can think of is like a dental example, actually. So and please forgive me, I don't know the exact medical terms for this, but there is an algorithm that essentially was fitting your mouth for a particular, they didn't use it as a dental one, but it started out in a dental specialty where they were looking at the shape of your mouth and understanding kind of the different ways that your jaw develops and the teeth develop. And then our sleep apnea specialty found out about that algorithm and said, wait, you can actually use that to fit the right CPAP machine on a particular patient. So when you get a CPAP machine, there's like hundreds to choose from, and there's so many brands. So use that algorithm to say, actually, based on the picture of your mouth, we might be able to recommend a specific. So that's one that went from, we started out as research, now it's into that.
Great, yeah, nice to hear, thanks.
Yeah.
So I just wonder with Mayo Clinic, what you're saying all the way in the beginning, you're not for profit. Where does it come through?
Where does our nonprofit status come from?
I mean, more like because you're you were saying that you had a lot of focus on research, and
Yeah.
I wonder, like, does it go all the way to the point that you share your insights beyond your company, or is it not the case?
Are you just talking specifically about the data as well?
Yeah, or like the AI models that you just to
Sure.
etc.
Sure, yeah. So I should say Mayo Clinic Enterprise, right? We have a nonprofit status because we are a teaching institution. We also have like a school of medicine and different medical programs. We also provide care, so we are a hospital system. And then we do have laboratories. So a lot of our information, kind of sifts through all three shields. But as far as like sharing insights publicly and getting, part of our learning is, one is I would highly recommend our website. it's just so much information that can get you like to the weirdest things, right? So whatever specialty or diagnosis or even symptom you have, you can get lost in the Mayo Clinic maze is what we call it, Mayo Clinic maze. But as far as the data and algorithms, we have several programs that now have offered to work with startups and other private and public sectors that help with collaboration as far as like we have a model and we want to test it out on new data. Mayo Clinic has a program now called Mayo Clinic Platform, which is essentially a place where different cohorts of startups, public, private sector groups can work with a physician and a clinical expert, as well as our teams, our service teams, that can really help facilitate, if you want to work on a particular specialty condition, we will try and match you with the right team. Maybe there's opportunity. I mean, we always have partnerships with different vendors, institutions, educational centers. I think you name it. Like, I can think of one now. We have a strong partnership with ASU in Arizona, where we work with the data scientists in their lab. But it's really kind of a national program that's being offered with the Mayo Clinic platform. As well as like international work that's now starting to begin. Yeah, I believe Mayo Clinic platform, not many of those startups this year are from the United States. Like we started partnering with different groups in Greece. Funnily enough, it's because of the regulatory piece. Like they don't have as strict of a regulatory piece there, so they ended up working and basing. But all international, it's not just one country.
Thank you. That was a good segue into my question on the regulatory environment post-COVID. Obviously, you've been in the industry for a long time. You mentioned the FDA has quite a high burden of proof barrier, particularly in the early stages, but it would take up a lot of resources to get across the line, whether it be clinical trials or not. Did you notice a shift in the burden of proof, perhaps reducing as a result of how the vaccines were fast-tracked and sort of a change in the regulatory environment, perhaps as a result of a precedent being set?
Yeah, so maybe I might answer the question in terms of, I mean, documentation in itself is a big arm of and big endeavorment, right? And I can't say for sure if I've noticed a difference post-COVID, just because I didn't work in this space prior to COVID. But what I will say is that the documentation, documentation doesn't mean deployment. Just because you did all the paperwork doesn't mean that you've successfully deployed the model. It just means that FDA recognizes it. But after COVID, we really get to see the shift culturally as far as the FDA has this far with medical devices, and other health institutions are saying that's not even enough, right? So at Mayo Clinic, we're trying to increase the burden. This sounds really ridiculous, but we're trying to make sure that we surpass FDA standards with documentation. Just because a lot of times regulatory bodies are, a few years behind, as well as healthcare, right? So healthcare and technology is slower in some senses, in some aspects, than it would be, let's say, like the car industry, the automobile industry.
But in the end of the day, you still have to filter through the FDA, despite having a higher or more stringent
Yes.
requirement.
Yeah, but it depends on what kind of medical device, right? Because the FDA also has different classes. Yeah, so class 1, super low minimal amount. Class 3, a year's worth of paperwork, right? So it depends on what kind of device you are. And I hate to answer that way, it depends. But
Self-regulation in some sense.
yes,
Yeah.
that's a good point, yeah.
Hi, quick question. How do you ensure that your ideas or user friendliness doesn't get diluted in the process of development, especially with all the regulatory requirements that you have to adhere to?
Yeah, that's an excellent question. The only way that I can confidently answer right now is to have that user advocate in the room at all times, at every meeting. And that's not always possible, but that's what I mean by deepening the UX mindset is if we start to ask earlier, what do users need, the better, right? So if we ask that towards the end, the amount of rework that we have to do to just interview a new kind of user or a new user segment is going to be months and years. Maybe I'll take this time actually to answer a question with a short story that helps kind of answer the question. I did a little bit of user research with pediatric physicians and the likelihood that a patient would have an asthma attack. Their algorithm predicted, X amount of time, the likelihood that a child will have an asthma attack. And they brought us in towards the end. Model looks great. And we did some user research with their clinicians, and it didn't occur to, well, I should say, a key lesson is that part of the output of the model wasn't just, in 3 months, you're likely to have an asthma attack, was the clinicians really need to see additional context. Well, like, how is this even calculated? Can I see the latest test results? Can I see the latest medications so that I can feel confident in relaying this message? And those two key pieces, the latest test results and medications, was not on the screen of the AI output. And so we have to go back and add that, not just in the UI, but now those are key model features that have changed the model itself. So it's as early as possible. Try to get everyone in the room to ask about the users, not just the user advocate or the user researcher or the UX designer as early as you can. Yeah, I guess I'll leave it at that because I think that's what's worked best for now. Hi.
Could you talk about this current model here, and how can we use that to leverage UX design?
So I'm just going to repeat it back and make sure I got it. We're interested in learning more about model care and how UX is built into that process. Excellent. Okay. So there is a very complicated part of model care towards the end, especially at the end now. So we're talking about lifecycle management, where model works great, it's up in production. We actually have dedicated MLOps teams that maintain models, both technically, operationally, and working on QMS systems to maintain that. So it's actually very similar to a UX process where, let's say you get a complaint about your model. Well, now, with the documentation in parallel, what are you going to do with that information? How do you prioritize that feedback? Same in the UX process. I gather so much evidence, we start to sift through it and gather summaries. How do I know which feedback to listen to? It's the same in our model care work, right? So we actually teach data science teams how you prioritize feedback and which orders, like which one can you handle now and which one do you want to handle in the future. So I see them as actually very similar processes, just maybe have different names. And I see that actually throughout everywhere. It's crazy. It's sort of like when you say the word translate, depends on who you're talking to. When you say the word validate, like I could probably come up with a dictionary that has different terms based on the different role. The word like testing could mean different to an IT developer than your clinician. So it's really a semantics barrier sometimes. But I think they're just very similar mindsets, they just are named differently. And one of the things that UX brings in particular, though, is that usability. There are times where we have model developers who think something is usable, right? And we start to test it, and people can't see the most critical pieces. They can't see the context for selecting something. They don't know what actions they need to take. So I really feel like, though, the UX heightens and enhances the model care by doing usability studies, by communicating with users and actually sending it out there. I often find that not a lot of teams feel like they should do that or can do that. They feel like they're really, this is the scope of my work. I hand it off to somebody else to do that. But it's really kind of a similar process. So I would like to just kind of end by saying it's about that usability rather than just functionality that we need to really push our other colleagues towards. Yeah, you're welcome.
Thank you so much, Kristelle. Can we get a huge round of applause to Kristelle?